This program is brought to you by Emory University.
Okay, everybody, what you see there on your screen is Dr. Kasra Moazzami. Kasra is originally from Iran and did his residency at Rutgers. He's a member of our clinical investigator track and is currently a fourth-year fellow who is scheduled to graduate next summer. Go ahead, Dr. Moazzami.
Thank you very much, Dr. Williams. Sorry again for the connective issues that I had. Good morning, everybody. Yeah, the topic that I want to speak today about is mental stress and cognitive function in coronary artery disease. And the reason I'm want to discuss about this topic is that dementia, cognitive impairment, and cognitive decline, all these terms are issues that are growing in proportion. They are increasing in prevalence. Right now, we have around like more than 50 million people worldwide having dementia. And as the burden of the disease is increasing, the question is that we as cardiologists, what is our role? Do we have any way that we can contribute to the prevention treatment of cognitive impairment? Yeah, so is there any relationship between coronary artery disease and dementia? And the answer is yes. We know from multiple studies that there is a link between coronary artery disease and dementia. People who have coronary artery disease on average have a worse cognitive function than the general population. It had been thought that over the past decades, most of this reason is because of the shared risk factors that these people have. We know that hyperlipidemia, diabetes, hypertension, congestive heart failure, these are all factors that are shared between patients with coronary artery disease and dementia. So the question is that the only thing? And is that the reason why these two are linked together? That has been thought until like most recently, there have been studies that have been done. The most prominent one is this study published a couple years back, where they looked into a large group of patients, more than 20,000 people, with or without coronary artery disease. This is done from the English Biobank. Among these 20,000 people, they followed them up for 14 years. The thing about this cohort was that they were able to have multiple cognitive function testing during the time. And because of that, they were able to really follow the trajectories of cognitive function over time. So what we see here, we see the blue line and the red lines. The blue line represent those who do not have coronary artery disease. As you can see, we have a steady decrease in cognitive function, which is mostly related to age over time. In the group that is red, which those who develop coronary artery disease around the 7th or 8th year, what we see here is that before the coronary artery disease, the cognitive trajectories are similar. And it is exactly after the incident coronary artery disease, which could be due to an MI, diagnosis based on a cath or a positive stress test. But what we see is that after the diagnosis is when you have a steeper decline in cognitive function over time, which really could not be explained by those common risk factors we just mentioned, because those common risk factors exist even before the incident coronary artery disease. So there is something else going on here that worth investigating. While this study was the most well presented one with a large group of patients, there have been multiple other studies as well that have came to the same conclusion, and that there is something about coronary artery disease beyond the risk factors that is causing this decline in cognitive function. So what is that? And one of the things that I'm going to propose, and we're going to talk about the evidence behind it, is mental stress. So mental stress, the first step is to talk about mental stress and coronary heart disease and how mental stress affects people with cardiovascular disease. So I'm going to talk about how mental stress causes myocardial ischemia, mental stress causes vasoconstriction, vascular dysfunction, mental stress causing endothelial dysfunction, and inflammation. So the first one part, mental stress and myocardial ischemia. So we have a phenomenon called mental stress-induced myocardial ischemia, which happens around 30% of people who have coronary artery disease in response to an acute mental stress challenge can develop ischemia. So your typical patient with this scenario is the one that is shown here, where in A, after a mental stress challenge, you can see areas of the heart that develop ischemia. But what is interesting about this patient is that in response to physical stress ischemia, so exercise, treadmill, or nuclear stress test, they do not have ischemia. And of course, that area of ischemia is not present during rest, which is shown in C. So as I said, around 30% of patients with coronary artery disease have this phenomenon, which means that it's not the atherosclerotic process, given that they may not have a positive stress test with the conventional stress test, and it's only with mental stress. And a meta-analysis that was done back in 2014, and of course the data is now similar to that still, showed that after you have mental stress ischemia, the risk of developing major cardiovascular events is over 2 times more than patients who do not have mental stress ischemia. And which is similar to a patient with a positive conventional stress test and indicates that this can also be used as a prognostic factor. So mental stress can also cause vasoconstrictive behaviors in patients with coronary artery disease, which is different than a patient that does not have coronary artery disease, which is usually vasodilation. And this is a phenomenon that I'm going to discuss a little bit about right now. So one of the ways that you can measure vasoconstriction is through a method called peripheral arterial tonometry, or PAT, which is basically a probe that you put on the finger of patients. And what it does is that it can detect the changes in microvascular pressure, and based on that, detect if a patient has a vasoconstrictive response or not. A typical example is what I show in the right side. Here we have a patient which the left part is during rest. During the mental stress procedure, the upper panel, you see that there is no difference really in the signal that is being detected, while we have another patient that during a mental stress procedure, this signal is decreased significantly compared to the rest period. And the way the PAT is calculated is that you divide the amplitude of the signal during mental stress to the amplitude of the signal during rest. And the smaller the ratio, the smaller your PAT ratio, the more vasoconstrictive response you have. So a couple years back, one of our fellows, Zhuang Huan, who has graduated last year, did a very interesting study where he looked into this vasoconstrictive response in the patients with coronary artery disease in response to mental stress. What he did was that he divided patients into those with low PAT ratio, which indicates more vasoconstriction, and those with a high PAT ratio, or those with a less vasoconstricted. When he divided these two and he followed these patients for 3 years, as you can see here, he saw that those who had a lower PAT ratio or more vasoconstriction, they had worse cardiovascular outcomes compared to the other group, which indicates that the mental stress causes vasoconstriction, and response, it has a prognostic significance, and which is different than those who do not have this vasoconstrictive response, and can predict outcomes, more importantly. What about endothelial dysfunction? We know patients with coronary artery disease have endothelial dysfunction, but what is more interesting is that in a group of them who in response to mental stress, you can aggravate and exacerbate the endothelial dysfunction compared to the other group. So the way we measure endothelial dysfunction, there are different ways, but one of the non-invasive ways that is the most common way that we measure it is through a technique called the flow-mediated dilation, or FMD. So the way it works is that we have a cuff, and we inflate a cuff distal to the brachial artery of the patient. We measure the brachial artery diameter before at rest, and then after you inflated the cuff for over 5 minutes, while you're causing like some small levels of ischemia in the distal to the brachial artery, that in return causes vasculature dilation and decreased vascular resistance. After 4 or 5 minutes, when you open the cuff, what happens is that you have a dramatic increase in blood flow, which causes increase in shear stress. And that increase in shear stress releases vasodilators, nitric oxide. And if you have a healthy artery, you would have an artery dilation. So by measuring the artery diameter before and after you release the cuff, you can have it as a surrogate for NO-dependent, or better to say, endothelial function. So if you have a normal artery, you have a vasodilation. If you do not have a normal artery, you would not see that vasodilatory response. So Bruno, another of our fellows that graduated last year, did a very interesting study where he wanted to see how, in response to mental stress, you would have changes in the endothelial function and how that could relate to coronary artery disease. So first, what he looked at was a pre-stress FMD, where basically he had divided his coronary artery patients into those below and above the median. This is before he did any mental stress or anything. And then when he divided them and he followed them up, really, as you can see here, there is no difference between those with high or low FMDs. However, when he looked at the FMD response to mental stress before and after, what he did see is that among those patients who have endothelial dysfunction, which he defined as not having that vasodilatory response during mental stress, he saw that patients who do not have that vasodilatory response, shown in the blue, or those that have transient endothelial dysfunction otherwise, they do worse and they have a higher probability of major adverse cardiovascular events over a 3-year period. So once again, shows that endothelial dysfunction induced by mental stress has prognostic implication and affects outcomes in groups of with cardiovascular disease, while even the baseline FMD, which is a prognostic factor if you consider the whole population, patients with and without cardiovascular disease. But if you just look at those with coronary artery disease, you really cannot differentiate it and use it as a prognostic factor. And the final part is mental stress and inflammation. Multiple studies have shown that patients with coronary artery disease in response to mental stress have an exaggerated inflammatory response compared to the control or the normal population. One example is a study that Mohammed Hamadan, one of our fellows, did a few years back, showed that in response to mental stress, you have elevated IL-6 levels, MCP1s, MMP1s, all significantly increase, around 30 to 40% increase, while you do not see this increase in the normal population. And in a more recent study, we have shown that this is actually prognostic in, especially in women. An increase in IL-6 level is associated with worse cardiovascular outcomes. For every standard deviation increase in IL-6, in women specifically, you saw a 50% increase in major adverse cardiovascular events, which again points to the fact that the inflammatory response, not the baseline inflammation, but the inflammatory response to mental stress in patients with coronary artery disease could be used as a prognostic factor. So coming back to this slide, we see that mental stress causes through myocardial ischemia, vasoconstriction, endothelial dysfunction, inflammation can affect the heart. But the question is that what about the brain? How does mental stress affect the brain? Well, most of the studies that I've done in this area, they have focused on the general population. There is not that much focus on specifically the coronary artery disease. And we believe that the patients with coronary artery disease may act differently to mental stress compared to the controls and those without coronary artery disease, based on all the data that we showed. So we thought it is important to have a better understanding of how mental stress affects cognition, and particularly in this population. So one of the studies that we did was to look into the role of chronic psychological stress on cognitive function in coronary artery disease. What we looked here was that we had over 500 patients with coronary artery disease, and we gave them these questionnaires to understand the burden of psychological disturbance in them. So we had questionnaires for depression, PTSD, anxiety, anger, hostility, and perceived stress. And then we standardized all those scores and put them all together, come up with one composite psychological distress score. And what we were interested in was the executive function of these patients. So for executive function, just to give a review of how we do it, we have two methods, the trail A and trail B. In trail A, it's like either letters or numbers. You ask a patient to connect them sequentially. So from 1, you go to 2, to 3, to 4, and so on. In B, it becomes more sophisticated in a sense that it's like letters and numbers. So from 1, you go to A, then you go to 2, then you go to B. And really what you're measuring is the time that the patient or individual can complete the task. So the longer it takes for you to complete trails, either A or B, the worse executive function you have. And that is basically how you measure the executive function, one of the most validated ways. So when we did that and we looked into the relationship between distress scores and trail A's and B's, as you can see here, we saw a positive relationship, meaning that the more stress you have, the worse executive function you have, indicated by a higher trail A or B, meaning it takes more time for you to complete these two tasks. And that was independent of age, sex, race, education, cardiovascular risk factors. This showed that this group of patients are vulnerable to chronic psychological stress, and they do worse. Those who have a worse distress score do worse cognitively. And the next part, we looked into acute mental stress protocols to see how patients respond to that. Just to give a sense of what we do during this mental stress protocol. So we have a patient that initially we keep them in a quiet room, relaxed. You get their blood, you get their vascular function test, any type of test that you are thinking at baseline, you do it during that time. And then after that, there are two usually protocols. One is a mental speech stress and the other one is a mental arrhythmic test. During the speech stress, there are different scenarios. One scenario that is shown here, it says, imagine you have applied for your ideal job. You must convince the committee members why you're a perfect candidate. You put them in front of audience that will start giving you negative feedbacks while you're talking, in some way like aggravating you during that talk. You have a limited time to prepare and a limited time to speak, and that will be the component of your speech mental stress. And then the next step, you do the mental arrhythmic test, which is basically you ask the patients to try to complete or solve more and more increasingly difficult equation during a time constraint. And similar to a physical stress test, the way that you monitor the patients to see if you get a good response from them is by measuring their blood pressure, heart rate, and you expect the heart rate and blood pressure to go up. And based on that, you would see if they are actually responding to stress or not. And then you have a recovery phase. And during this stress time is when we are measuring the blood again and the vascular function and going from there. So one thing that we tried to do was that to see how the cognitive function of patients with coronary artery disease is between those who in response to mental stress show myocardial ischemia versus those that do not show myocardial ischemia. And as you can see here, there was a significant difference between these two groups. Patients who show ischemia in response to a mental stress challenge have higher trail Bs, indicating a worse executive function compared to those who do not have ischemia to mental stress. And just to understand if this was like an atherosclerotic process or not, as a control, we also, all these patients underwent our conventional stress tests, either treadmill EKGs or nuclear stress tests. And as you can see here, that we do not see any difference between those who develop myocardial ischemia to physical stress versus those who do not develop that. So it highlights really the relationship that exists in the coronary artery disease people is between really this mental stress condition and their cognition. And it's not the atherosclerosis that you may think that a person who has positive stress tests may have worse cognition, but we did not find that. And this is similar to previous studies. So now that we know that there is indeed a connection between mental stress, the coronary artery disease, and dementia, the question is that, okay, so what are the mechanisms? One of the mechanisms that we were looking into was the vasoconstriction. We saw that mental stress in coronary artery disease causes that vasoconstrictive behavior. The question is that a contributing factor to also the dementia and cognitive impairment we see in this population or not? So once again, we can see here, we had two group of patients, one that did not show vasoconstriction, two mental stress challenges. We had 68 patients of our group, of our cohort with coronary artery disease had that. And the majority of our patients with coronary artery disease did vasoconstrict in response to mental stress. Over 320 patients were our vasoconstrictors. So when we can compare these two groups with respect to their executive function, as you can see here, we saw that those who had vasoconstriction had higher trail Bs and therefore worse cognitive function compared to those who did not have vasoconstriction. And when we did our logistic regressions, we saw that actually these two groups are particularly different with respect to vasoconstriction, and this could be a marker really to dissociate these two groups from each other. Another thing we looked into, when we looked into those who had ischemia in response to mental stress, and we already established that these people had worse cognitive function over time, we wanted to see if the vasoconstrictive response plays a role here. And what we did see was a significant relationship, and in fact, more than 30% of the relationship between ischemia induced by mental stress and changes in cognition over time is due to peripheral vasoconstriction. And that was something we found here. So that was one mechanism. What else? What else can be the relationship between mental stress, coronary artery disease, and dementia? The other one is brain activation. Of course, the mental stress starts with the brain, and that is where all the signals are perceived. And that is how you perceive mental stress. So it was important to see how the brain reacts to this. To those that remember my talk from last year my focus was to understand how mental stress affects the heart as the real outcome and through the brain, how mental stress affects the brain and through the brain affects the heart and cardiovascular outcomes. And two studies that I talked about, one was when we looked into an area of the brain in the frontal lobe called the rostro-medial prefrontal cortex. This was important for us because it was a higher brain region that controls stress and fear. It regulates autonomic function. It regulates inflammation. So the question was that how this area affects cardiovascular outcomes. And what we saw was that when we divided patients into those with high versus low RMPFC activation, we saw that the group that is highlighted red and the group that has higher brain activation in response to mental stress does worse over time. And a matter of fact, this group is more than 3 times higher to develop cardiovascular events compared to the group that does not have higher brain activation during mental stress. And then we looked into their mechanisms and how that was. But another thing that we looked in was also to look into chest pain, angina, and how the brain response to stress affects your perception of angina. And we looked into an area close to the RMPFC called inferior frontal lobe, which is particularly activated with pain. And the hypothesis was patients who have more angina have higher activation in this area. And as a matter of fact, that's what we saw. So we saw that based on the amount of activation that you have in response to mental stress in this brain area, you can see how patients with angina react. So those that do not have any angina, they have a lower inferior frontal lobe activation compared to patients who have daily and weekly angina, which have the highest brain activation in this area. And those who have monthly angina are something in between. So that was then. Now, this time we want to see like how the brain is affected from the heart and how the heart contributes to the cognitive function and particularly how mental stress plays a role in this relationship. So what we did is that we had our trail B as the variable that we wanted to see what are the predictors, and we looked into every variable that changes during mental stress to see which of these are actually independently related to executive function. And what we found was that, of course, the vasoconstrictor response that we spoke previously is related. The norepinephrine response to mental stress is related. The higher your interleukin-6 response is to mental stress, that is a prognostic factor. And of course, the most strongest factor was activation of the inferior frontal lobe, which we used as a variable to investigate. So when we try to now look into the different mechanisms, how all of these pieces can be put together, we came up with this a significant model where in response to mental stress, you have a higher inferior frontal lobe activation that by itself causes changes in your trail B over time and contributes to over 50% of this effect. But also the activation of the inferior frontal lobe also causes an increase in norepinephrine levels, an increase in IL-6 levels that contribute to worsening executive function over time. And finally, around close to 20% of this effect is through the peripheral vasoconstrictor, meaning that inferior frontal lobe activation to mental stress causes more peripheral vasoconstriction, and that in turn causes worse executive functioning over time. So, and this was our working model where we would presume that in response to mental stress, we have an increased inferior frontal lobe activation, which in turn causes increased catecholamine release, causes increase in the level of inflammation, and finally causes increased peripheral vasoconstriction. All of these mechanisms independently cause you to have a worse executive function over time. So that being said, we really cherry-picked that area of the brain, the inferior frontal lobe, and that was because we had a hypothesis on it, and we had an explanation why we chose that. But in reality, what we see is this figure where different brain areas, almost all of the brain activates or deactivates in response to mental stress. As you can see, this figure having like different slices, sagittal slices of the brain in response to mental stress, we see activations mostly in the inferior lobe, mostly in the frontal lobe. With this area was the inferior frontal lobe, which we were investigating before, but we also see a lot of deactivation. You see that mostly in the occipital lobe, you see it in the parietal lobe, and so forth. So the real question is that how is the brain? Brain doesn't work into one area being activated, one area being deactivated. It works in a network. So the bigger question, which will be something we're working on through machine learning and so forth, is that how can you come up with a network of brain activation and deactivation that ultimately decides your response to mental stress and your cardiovascular response, and finally your response to cognition. And that's the open question that we are working at this moment on. And the final part of this, which I think is the most exciting part, is mental stress through what are the molecular mechanisms of how mental stress affects cognition in this population. When you talk about the molecular mechanisms, the importance is that this is where interventions can happen. This is where you can develop new drugs. This is where you can understand the pathways that are effective to mental stress. Yes, we have vasoconstriction. Yes, we have these brain areas that are activated and so forth. But what are the molecules and metabolites that are changing that is causing the effects? Understanding that will be the next step to actually being able to make a difference by changing those pathways and affecting the cognition in a positive way. So that's why we have been interested in the metabolomics. As you can see here, there has been a trend in studies starting from the genome, with the genomics, moving to the transcriptome, which is the mRNA studies really, moving into the proteomics. And finally, in the past decade or so, focusing on the metabolome of a human being, which is basically these small molecules or metabolites that have function. And that is the closest you can get to the phenotype of a human, a phenotype of an organism, a phenotype of a cellular or any subdivided function that you think of. The closest is those metabolites that have function. Another thing that is interesting about the study of the metabolome is the role of environmental influences. So the metabolome is not a fixed thing like the genomics or to some extent the proteomics that is mostly related to your genome and your epigenome. It's changes based on the influence of the environment. So in some way, the metabolomic study is the crosstalk between what an individual has as his genomic and what the environmental factors are affecting that. And what it becomes even more interesting for us that are studying mental stress is that the metabolomics is dynamics. It changes with any perturbation in the system. So we're thinking that during mental stress, what happens to your metabolomics, what changes you have. And based on that, we can understand the molecular mechanisms underlying the stress. So we have been very interested in this work. This is an unpublished work that I'm showing here right now, where basically what we had was that we had this group of patients with coronary artery disease, around 100 of them. We did them, had collected their blood at baseline. We then stressed them, and then we collected their blood like 90 minutes after stress. And when we look into the metabolomics at baseline and the metabolomics after mental stress and see what is changing, this is the figure that we get. As you can see, thousands of metabolomes change in different magnitudes. So the ones that are shown blue to the left of the 0 sign, those are the ones that decrease in response to mental stress. The ones that are on the right side and are marked by red, these are the metabolites that increase with mental stress. So the next part would be, okay, so what does this mean? And that is the difficult part in metabolomics research, is really to now narrow down this like huge amount of information that you have through different pathway analysis and bring it down into specific mechanisms of how these metabolomics can be related to. What are the networks that these metabolomics, those that go increase and decrease, and all together, how they affect the individual. And or you can look into single metabolites. For example, one metabolite that we're very interesting, it increases more than 6-fold, as you can see here, is phenylalanine. Phenylalanine is a metabolite, is an amino acid that is becoming more and more increasingly exciting in the world of the cognition, because this is a metabolite that they've seen it increases in people with dementia. They see a higher increase in the CSF of people with different dementia subgroups. So it's a metabolite that is actively working. And it's interesting that when we looked into these two, we saw like a metabolite like phenylalanine has such a dramatic increase, something that is already known that has an effect in patients who have cognitive impairment and dementia. But of course, the bigger picture would be how to narrow all these changes into one cohesive network of changes, and how that would affect cognition. So what are we moving from here? What are our future directions? So all the data that I showed here with respect to the cognition, coronary artery disease, and mental stress were all based on the information we had at baseline. So during cross-sectional studies, we looked into the vascular function, the brain, the metabolomics, and all the data that I showed you was all from the cross-sectional. Of course, the next step would be the longitudinal portion of this study and how these changes that we see at baseline affect cognition over time, which is really the interesting part, because this is how you can predict those who would develop into dementia versus those who may have cognitive impairment, but the progression of the disease won't be that significant over time, and they won't get worse, versus we may have another group that at this moment we actually didn't detect them to have much of a cognitive dysfunction, but over time they have a quicker decline and get worse over time and develop dementia over time. So same question, but with a different way to analyze. So, and that would be basically what my role will be in the next few years. That's this aims, and this diagram that you see here is what we submitted for my K23. And basically what we're going to do is that we have this individuals with coronary artery disease, around like 149 of them, who underwent acute mental stress. These are patients that had their mental stress done during the years of 2010 to 2014. We still have all these patients available. And then what we're trying to do is to develop a new 10-year follow-up period where I'll bring these patients back during my K23 award and do again cognitive tests, vascular function test, and so forth, and then look into the changes in brain activity over time, looking into the changes in their vascular function, looking into the changes in metabolomics, and how that relates to changes in their cognition over time. And really the purpose of this work will be going from association, which we right now see in our cross-sectional part, into causation, and that would be our goal. So with that, I wanted to thank everybody for listening. Of course, I wanted to thank all of my mentors who really helped, our collaborators and our funding that helped produce all this work. And with that, thank you for listening. I'll be happy to take any questions. I believe Dr. Williams had to leave. He told me yesterday. So if you guys have any questions, feel free to go ahead and ask me. I'll be happy to answer.
Kasra, can you hear me? It's Stan Sherman.
Hi, Dr. Sherman. Yes.
You know, this was great. But you're dealing with this group of coronary disease patients, and you know, and you have some controls and those who respond and don't respond. But how does their baseline, you know, beta blocker and statin therapies that have been known to, affect cognitive function somewhat in the past. And how do you account for that in terms of your controls versus your coronary disease subject?
Yes, thank you. That's a great question. And we have data that not from these cohorts, but that, for example, ACE inhibitors are reducing among all the cardioprotective medications that we have a cohort that has been looking into that. It has nothing to do really with mental stress. It's just to see which one of our cardioprotective medications affect cognition over time. And one that jumps out right now, and that's like has been a big paper came out last year, is ACE inhibitors. And ACE inhibitors, it seems in this population, reduces your progression of cognitive impairment over time. Again, when we look into baseline on our studies, we did not see necessarily an effect, independent effect on medications on the cognitive status at baseline. But as I said, that is probably not a good design that we have because it's on cross-sectional. What is important to see is to see where over time, how the cognition works from these patients. But yeah, that's a great question. Thank you for that.
Kasra, Mohan Jokadar here.
Hi, Dr. Jokadar. Yes.
That's a great talk. But I wanna, I wanna sort of build on what Dr. Sherman just asked, because I think this is a very important issue.
Yes.
Beta blockers cause cognitive dysfunction.
Yes.
Beta blockers. So really the question is there a way to parse the effects that you see from mental stress, from what we do to the patient, including beta blockers, statins, etc. And also, is there a way to mental stress from depression, and its own sort of entity. Also, I saw that you used surveys for chronic mental stress and experiments for acute mental stress. Are those one and the same in your, or is there, have you found differences in those two? And then my last comment is, our medicines, that we're programmed to give, we just have to be honest about how effective they really are. For example, beta blockers, correct me if I'm wrong, have no survival benefit in folks post-MI outside of their benefit on heart failure.
That is correct. Yes.
That's not been, as far as I know, that's not been demonstrated in double-blind clinical trials that beta blockers have improved survival. So if someone has a small myocardial infarction and they're having side effects from the beta blocker that we're giving them, how necessary is that beta blocker really? But that's an entirely different question. It really is, how can we tell that our medicines aren't partly to blame for some of the things that you're seeing?
Yes, thank you very much, Dr. Jokadar. All great points, and thank you for bringing these up. With respect to medications, that's a great question to ask. So there are two things that we're looking at here. We're looking at these patients who have coronary artery disease, who are on a bunch of medications. The question is that how that affects their cognition over time. There have been a number of studies that have been doing that, but when it comes into the role of mental stress and that interaction with that, we don't have any data on that. One thing that we do in our protocols when we do our acute mental stress challenges, we ask patients not to take, especially beta blockers, because it will not let us have that that heart rate response and blood pressure response during the mental stress. So patients who all get the acute mental stress challenges, we have a period of washout around like 24 hours that they're not on beta blockers. They still stay on ACE inhibitors, but at least for beta blockers, we don't have that. So all the effects that we see are off beta blockers in some way to say. That being said, it is interesting to see, and that is part of the work that we're going to do when we collect these patients back and we look into their mental stress over time, and of course, hopefully their compliance with their medications, and then look into medication compliance and different cardioprotective medications that we have, and what is the role of that for their cognition. That's an open question that we hopefully will be able to answer when we will be able to look at them longitudinally. With respect to your other question, the third part, I think I missed the third part. If you can repeat.
The third part was just a comment about
yes.
about how necessary beta blockers are. Is it necessary for all coronary disease patients, or do we need to be a little bit more selective?
Yeah, I agree. And we don't know the answer to that. And I think the other part of your question was the chronic versus acute psychological disturbances. That is true. So what we have is that we first at baseline, when we get all our patients, we collect all these information on their chronic psychological scores, including depression. And then the acute mental stress is a completely separate part. That is the experimental part that we do. And when we collect blood before and after, vascular function before and after, and we collect the data. And the idea is that when we collect these patients back after some time, once again, redo all the chronic part of it and see how is their like depressive scores got worse? Are they more depressed? Are they less depressed? How is that? And how is that factor in their cognition over time? So that is a piece that we're thinking about to add as well when we bring these patients back. We do not think, we're not planning of doing a repeat acute mental stress. That's really because of the budget issues. During my care, I won't have enough money to really do all these tests again. So we will be relying on data we have at baseline with respect to acute mental stress. But with respect to the chronic mental stress, we will be bringing all these patients back and repeating all those questionnaires and going from there. Thank you very much for that. Okay, I think I'm also responsible for ending the talk. That was what Dr. Williams asked me to do. If there are no other questions, I wanted to thank everybody for listening. Sorry again for the interruption, network interruption. It was at the beginning. Thank you all for listening. If there are any questions, I'll be happy to ask later as well. And have a wonderful day, everyone.
The preceding program is copyrighted by Emory University.